Okay, good afternoon, everyone. Welcome to our webinar from Kuala Lumpur and parts of ASEAN and also Australia and Oxford, UK. So with us today is our eminent speaker, Professor David Worrell, who will be talking on the subject of clinical approach in diagnosing and managing snakebite in Southeast Asia 2021. So I would like to first welcome everybody to this webinar. This is going to be recorded and we will be able to review the video later if we miss any points. So let me first introduce Professor David Worrell. Professor David Worrell is the Emeritus Professor of Tropical Medicine, University of Oxford, and holds honorary chairs in China, Peru, and Myanmar. He was formerly the head of the Nuffield Department of Clinical Medicine in Oxford and founder in 1997 the Oxford Tropical Medicine Research Network. He was a founding director of the Global Snakebite Initiative, and he is continuously doing research on snakebite in India, Vietnam, and Myanmar, funded by the Hamish Oxton Foundation, a UK charity. His career has been as physician, zoologist, teacher, researcher, resident, and traveler in Africa, Asia, Latin America, and Papua New Guinea. His publications covers infectious, tropical, and respiratory diseases, venomous animals, envenoming, plant and chemical poisoning, and expedition medicine. So we will first have our eminent speaker to present the topic for about 45 minutes. And this will be followed by our Q&A forum session, where Professor Worrell will be joined by the rest of our panelists from Southeast Asia, from Philippines, Indonesia, Thailand, Myanmar, Vietnam, and Malaysia, including Indonesia as well. So without further ado, I would like to invite Professor Worrell to share his presentation.
Thank you very much, Carl. Well, I hope you can see my first slide full screen. Thank you very much, Carl, for that kind introduction. I'm very flattered to be invited. I do have a sort of link with Malaysia and Singapore. I was born in Singapore. My sister was born in Johor Bahru. So a part of my heart, at least, is in your part of the world. So I'm very happy to be back with you virtually today. So I'm going to talk today, looking ahead to 2021, and trying to be a bit provocative to provoke some discussion. My title is represented on the slide here by different aspects of the clinical examination and assessment and bedside assessment and treatment of snakebite in the ASEAN region. Earlier this year, I reviewed the 2 editions of the WHO guidelines for Southeast Asian region, also the African region, in the face of some published criticism in the British Medical Journal. And this was very stimulating. And as a result of this, I've chosen these 9 areas that I'm going to try and discuss today. So ranging from the herpetological, recognizing some of the newly recognized species of medical importance in your region, and going on right through to some very practical issues of snakebite management, such as fasciotomy. So starting with the snakes, newly recognized medically important species, and as far as Thailand is concerned, 2 recent new records of the genus Protobothrops. So Protobothrops mucrosquamatus has been recorded for the first time in the northeast of Thailand, in Nan province. This particular snake inflicted a dry bite, I'm glad to say, but at least the species is now recorded. And not long afterwards, a very exciting occurrence of a new species, Protobothrops kelomohi, from the Okmoi district, this now in northwestern Thailand, in Chiang Mai province. And a bite by this newly discovered species caused severe envenoming. The patient developed profound coagulopathy with rhabdomyolysis and severe local envenoming that was treated with fasciotomy. Well, I'm going to talk about this rather controversial issue of fasciotomy later. So here is the new species. This is a specimen, a juvenile I photographed at Satan Sawapa in Thailand a couple of years ago with Dr. Lawan Chanhom. And as you can see, it is distinct from Mucrosquamatus. So two species now of Protobothrops, and we know their potential from the clinical literature in other countries, at least where Mucrosquamatus occurs. Now moving to Myanmar, and you may remember that a new species of spitting cobra was published a few years ago by the late Joe Slowinski and Wolfgang Wüster. This is Naia mandalayensis. Our recent study, which is part of an Australian government-funded project in Upper Myanmar, recorded this species in Mandalay, Magwe, Zagaing, and Shan in Upper Myanmar. You can see immediately that it's quite a distinctive-looking cobra. It lacks any pattern on the dorsal side of the hood. It lacks either spectacles or a single eye, and it has a very dark throat right down to the lower ventrals. Our survey in Upper Myanmar, as part of this Australian-funded project, showed that it was the commonest cobra in Upper Myanmar, far more common than Nyakothia. And the clinical study showed that it was capable of causing local necrosis, which is a familiar feature of spitting cobras in other parts of the world, but also life-threatening systemic neurotoxicity. So this is certainly a species of some importance. It also causes spitting ophthalmia when it defensively spits its venom into someone's eyes. And this very nice picture by my colleague Julian White shows the difference between the spitting fang. A, B, and C are the fangs of Naia mandalayensis, the spitting cobra, compared to a conventional fang of Nyakothia. At least in Myanmar, Nyakothia doesn't spit. Though I know there is a population in West Bengal that's capable of spitting, but you'll see that the venom duct orifice is quite different. It's in a groove, and it doesn't have this very circumscribed appearance of the spitting cobra fang. Now to Sri Lanka, where there are some exciting discoveries as well. First of all, a non-back-fanged colubroid snake, Rhabdophis, formerly Balanophis celanensis, of the Natricidae. And this is found in the southwestern quadrant of Sri Lanka. And the single case report was of severe systemic envenoming, the bleeding including hematemesis and profound coagulopathy. And here are some pictures of this newly recognized non-front fang colubroid snake of obvious potential medical importance, and a very nice image of a youngish specimen by Vishal Santra. And this is the actual bite that caused the envenoming that was meticulously recorded. And you'll see here, this is my picture of another Rhabdophis species. This is Rhabdophis subminiatus from Thailand, showing the position of these fangs at the posterior part of the maxilla. And also from Sri Lanka, a new species of hypnale, of hump-nosed pit viper, hypnale zara, was described a few years ago. And this has now proved capable of causing local and systemic envenoming, including fatal envenoming in one case. And you see here the distinctive arrangement of the rostral scales at the nose, giving it the upturned nose. Now, some changes in geographical distribution. In Bangladesh, in the old days, Debois russellii was recorded, but when I was working there with Abul Foyz and David Theakston and John Harris in the probably about 15 years ago now, we could only find one dubious museum specimen. But more recently, Abul Foyz, working with colleagues including Ulrich Koch, have recorded Debois russellii in the western part of Bangladesh, round Rajshahi, but also down towards the Sundarbans. And it's clearly much more widely distributed than had been suspected. And this makes a very important point, that an extremely important, medically important snake can occur in a country and not be recognized for a long time. Of course, there may be some re-emergence, I don't know, but it's possible that it was there all the time and was just not noticed. And there have also been recent reports of Debois russellii occurring in this exciting part of northeastern India, in Manipur. Now, in eastern Malaysia, Carl was telling us recently that now Kauthia may have been introduced, or it's certainly been reported now in eastern Malaysia. And in Nepal, the distribution of Debois russellii has come to notice again. In the past, it was known from the western part of the country, from Suklapanta and from Badia, the national parks in Badia and Suklapanta. And according to Sanjeev Kumar, it's known from Triveni in the eastern Terai. But recently there have been reports of 2 cases of envenoming, of severe envenoming from the eastern Terai region. And the point here is that the distribution of a snake as important as dangerous, potentially dangerous as Debois russellii, is very important as far as training doctors to be aware of likely patterns of envenoming, and of course supplying appropriate antivenoms to treat these cases. So I think the message from this first part of my talk is we must keep alert for the occurrence of new species and unexpected species in new unexpected geographical locations. Now I'd like to move on to the update of this very important Registrar General of India's epidemiological study in India. We all recognize India as being the sort of capital of snakebite in the world because of its enormous numbers and great diversity, and also the very many centuries of experience of Indian doctors in treating snakebite. And the publication in 2011 of the Million Death Study really made an enormous difference to the perception of the scale, public health importance and scale of snakebite worldwide, and was a major contributing factor in changing the WHO's opinion and ultimately the world's opinion about the relative importance of snakebite. But recently, we've published an update of this study by Wilson Surawera and colleagues, covering the period 20,000 to 2019. Just to remind you, this very well-designed survey is based on identifying the causes of all deaths occurring in 7,000 randomly chosen sample areas throughout the whole of this vast country. Each of the randomly sampled areas includes a population of about 1,000 people. And the cause of death was ascertained by asking the relatives and neighbors, the bereaved relatives and neighbors of the dead person, about the circumstances surrounding his or her death, so-called technique of verbal autopsy. In the case of an event as dramatic, as memorable, and as distinctive as snakebite, this has proved to be a very reliable way of determining the cause of death. But you can imagine other situations where it would not be reliable. I mean, acute fever leading to death, such as malaria, it could be a lot of other causes as well. The great advantage of this survey was it was nationally representative. It wasn't just looking at one area and then extrapolating to the whole country. And finally, most important, it was not dependent on hospital returns, the sort of figures that governments and ministries usually have to rely upon. So this is the sort of result that is produced. This is in the period 2004 to 13, shows the spatial distribution of the risk of death from snakebite in India. And I think this is quite startling, because if you look at the scale here, which I'll explain, the risk of dying of snakebite before the age of 70 is as high as 1% in these red areas. 1% chance of dying of snakebite before you reach the age of 70. That's pretty appalling. And lesser degrees in other parts of the country. This sort of geographical distribution of risk should be very important for government authorities who are trying to deploy most efficiently, most effectively, scarce resources for preventing snakebite. So just a few details. During this expanded period of 20 years between 2000 and 2019, there was this direct estimate of 1.2 million deaths from snakebite, an average of about 58,000 deaths a year, but worryingly increasing, not quite as fast as the population, but certainly increasing each year. 50% of these deaths occurred in the adult age group 30 to 69, but very worrying, 28% among children less than 15 years old. Won't be surprised to see the vast majority were in rural areas. And again, very useful for deploying scarce resources. 70% of these deaths occurred in just 8 higher burden states of India. And interesting that 50% were below 200 meters above sea level, clearly determined by the distribution of some of the most medically important snakes, and equally important, density of human populations, agricultural populations in those lower altitudes. 77% of deaths occurred outside health facilities. Well, that's quite a familiar picture in many parts of the developing tropical world. And the deaths were very much concentrated during the monsoon, June to September. To put in proportion, this was one snakebite death in India each year for each one maternal death and for every 2 HIV/AIDS deaths. The figure derived by this survey was more than 20 times higher than the government of India's official figure, which is based on only a proportion, at least, of health facilities that report their deaths. This is just to emphasize the concentration, first of all, of deaths by season. Deaths in the solid line here, these are daily deaths. And you'll see that 50% are concentrated during this brief monsoon period, June to September. And just to make the point again about altitude, below an altitude of 200 meters above sea level, 50% of these deaths occurred. Now moving on to what is an extremely important and urgent clinical consideration for doctors managing a case of snakebite or suspected snakebite, and that is the rapid determination of whether the patient has a bleeding diathesis and coagulopathy, because this very common feature of envenoming by viperidae in this region, outside the region also with some elapidae, and some of the non-front-fanged colubroid snakes, is a matter of great clinical urgency to realize this risk of perhaps imminent fatal hemorrhage, internal hemorrhage. So first of all, the clinical evidence of this sort of hemostatic failure is persistent bleeding from the fang marks. In this case, this is 40 minutes after a bite by a Malayan pit viper, Callocelasma rhodostoma, or spontaneous systemic bleeding, often detectable in the gingival sulci. Then, if you're lucky enough, of course, the gold standard would be to have at your service a fully equipped and functioning coagulation, blood coagulation laboratory that can deliver rapid and reliable results. Things like the prothrombin time, the partial thromboplastin time, the fibrinogen concentration, and so on, platelet count. Unfortunately, in many parts of the world where snakebite is most common, coagulation laboratories just don't exist. And what is used there most often is a simple rapid bedside test, the 20-minute whole blood clotting test. And despite the fact that it's so crude and simple and so undemanding in equipment, the sensitivity and specificity is remarkably high for detecting gross coagulopathy. This is blood that is incoagulable because the fibrinogen concentration is less than about 0.5 grams per litre. So that's really very respectable sensitivity and specificity for detecting this degree of consumption coagulopathy in a snakebite victim. And I'm sure you all know the clear-cut difference. The end point, it's an all or nothing test. It's not a clotting time. At 20 minutes, the blood is either still liquid, indicating consumption coagulopathy, or it will still clot, indicating that there's still enough fibrinogen there for a clot. So this test is now very widely used in snakebite, in snakebite endemic areas throughout the tropical world, largely because of the lack of other convenient, affordable, rapid tests. It's admittedly relatively insensitive at detecting mild coagulopathy. So fibrinogens slightly higher than that roughly 0.5 grams per deciliter threshold, but still implying serious and perhaps evolving coagulopathy. The question is, does it matter if the test is negative in the face of evolving coagulopathy, provided that it's repeated at least hourly after the patient's admission to hospital while they're under observation? And a very critical point, this test relies on surface activation of Hagemann factor, factor 12 in the blood. And to get that surface activation, you need a proper glass vessel, preferably soda glass. It needs to be dry, it needs to be clean, and it needs to be new ideally, because if the glassware has been cleaned with a detergent or something else that has destroyed its surface activating properties, you will get a false positive result, which could lead to unnecessary antivenom treatment and inappropriate management of the patient. Of course, if you doubt the results that you get from the test, the 20-minute whole blood clotting test, the sensible thing to do is a normal control using blood from a relative or someone who's available. So if the result is incompatible with the clinical picture, you should certainly try and use a normal control. But I don't deny that a more robust and sensitive point of care method for assessing coagulopathy is urgently needed. And this would seem to be the obvious answer. This is a point of care INR machine, one of the ones, there are various manufacturers. I believe that the Ancillary from America has been withdrawn in some countries at least. The trouble with these particular machines is that they're proven unreliable. There's one paper on Indian Deboia russellii envenoming, and there have been several papers in Australia with Australasian elapid coagulopathic envenoming, showing that the point of care machine seriously underestimated the INR. And it seems that the procoagulant venom toxins in snake venoms, for example, the prothrombin activators, may act directly on the electrochemical substrate in the test, which is dependent on its endpoint. These are the publications I mentioned. And here's just one example from a case of tiger snake bite envenoming in Australia. The solid line shows the results of the laboratory INR, so starting actually more than 12, infinitely prolonged at this point, but then decreasing. And these in the red circle here are the results obtained by the point of care machine. See, grossly underestimated, dangerously underestimated, if you're assessing the risk of the patient and whether you're going to give antivenom or not. The other thing that could be measured with a point of care machine is the D-dimer as an evidence of fibrin lysis with cross-linked lysis of cross-linked fibrin. And these are the various machines, some of the machines. And in this particular case as well, with the tiger snake envenoming, the point of care machine gave a result of 0.24 to 0.73 milligrams per litre. The lab result was much higher. So again, a very gross disparity. So I'm afraid this, for the time being, this is not the answer. Another possibility is thromboelastography. And I know this is widely used in emergency units, certainly in the West. It's rapid, and it does correlate with familiar coagulation variables, such as fibrinogen concentration and platelet count. The trouble is it's unfamiliar to many physicians and snakebite doctors, myself included, I must say. I'm completely unfamiliar with thromboelastography. And so I would need a bit of retraining to understand the implications. And unfortunately, there have been no large surveys in snakebite victims, although there have been many anecdotal cases published over many decades, actually. This test had been around for a long time. So this is, to me, and I think many other physicians, snakebite physicians, the unfamiliar sort of presentation of results, a whole lot of parameters and angles and so on that are a bit mysterious if you're not used to it. And here is one study in which the correlation between what I would call a familiar parameter, such as fibrinogen concentration or platelet count, is compared to the different parameters, R, alpha, MA, and so on, K, of the thromboelastography. So my message here is, yes, we should give it a more formal try. We should test its practicability, its ease of management by non-skilled people, and its speed of results specifically in this variety of patterns of snake venom-induced coagulopathy. Now, moving on to something different again, this is the snakebite-associated hemolytic uremic syndrome. And there are various abbreviations, sometimes called HUS, it's sometimes called thrombotic microangiography, TMA, or microangiopathic hemolytic anemia, MAHA. And the features of this syndrome are mechanical microangiopathic hemolytic anemia with thrombocytopenia, which is often profound and prolonged, and acute kidney injury, which may require more prolonged, more repeated use of renal replacement therapy. And this syndrome is increasingly recognized and described in snakebite victims, both in the Viperidae, pretty well worldwide, but also in Australasian Elapidae. And the pictures here show the sort of clinical scenario, hemoglobinemia, indicating intravascular hemolysis, and the blood film showing these fragmented red cells or helmet cells or schistocytes. And I think the problem in the past is there's been far too little attention to looking at the blood film of patients with snakebite envenoming, and you have to fix the film properly with properly preserved methanol, something like that, in order to get a film which you can really look at carefully, which is sufficiently well preserved. And this sort of picture may be associated with evidence of thrombotic microangiography. In this case, this is a Russell's viper victim. You see deposition of fibrin in the glomerular and peritubular blood vessels, stained bright red in this particular section. So the reason I'm discussing this is specifically what is the role of therapeutic plasma exchange, also called plasmapheresis or apheresis, for treating snakebite-associated hemolytic uremic syndrome, or these other terms for it. And the reason I think we should think critically about this is that we're seeing increasing numbers of anecdotal case reports in the literature in which patients survived as a result of plasmapheresis, and the authors all too readily attribute that survival to the use of this certainly expensive, certainly potentially dangerous technique. So I think the problem is that as so often in snakebite medicine, we haven't maintained our position in the mainstream of general medicine. Snakebite management has often been regarded as a slightly eccentric, a slightly offbeat aspect of medicine. It's not, it's mainstream emergency general medicine. And we should be aware of what's happening in the literature and the research of mainstream general medicine. So I just remind you first about the classification of hemolytic uremic syndrome. First of all, there's typical HUS, which we all know about. This is sometimes called S-tech HUS. This is caused by Shiga toxin from E. coli and from other enteropathogens, damaging the vascular endothelium and triggering a very highly lethal problem of HUS. And the treatment here is, of course, antibiotics and supportive treatment. Then there's atypical HUS, which is a fascinating group of different diseases, a tremendous number of different conditions. And the causes are genetic or acquired dysregulation, particularly of the alternative pathway of complement activation. And one example is thrombotic thrombocytopenic purpura. The treatment, if you can confirm that it's TTP by measuring the Adams TS13 level and finding that it's reduced, then there's undoubted benefit in using therapeutic plasma exchange, plasmapheresis. Undoubted evidence it improves mortality in this subgroup of atypical HUS. If the Adams TS13 level is normal, then, and you can afford it, you're in a country that can afford this sort of treatment, eculizumab, which is an anti-complement 5 monoclonal antibody, has proved very beneficial in many cases. Then there's the secondary HUS group, and it's in this group that snakebite falls. There are many other conditions that can cause a secondary picture of HUS. And the treatment here is very often therapeutic plasma exchange is used despite lack of evidence, because, as you'll see here, because of the marked benefit of therapeutic plasma exchange in thrombotic thrombocytopenic purpura, this has encouraged its use across the board. For anything that looks like HUS, people have been tempted to use plasmapheresis, forgetting the theoretical basis for the pathophysiological mechanisms underlying. So that's the point, you see, the pathophysiology between these different conditions causing HUS is very varied. And in many cases, it probably represents not a problem with plasma containing, say, an autoantibody or something, but it's probably the blood vessel wall damage to the, as in the classic Shiga toxin induced HUS. And this is surely the more likely mechanism in snakebite. We know that, for example, zinc metalloproteinases, but many other venom toxins damage the vascular endothelium, activate the vascular endothelium, and they are most likely to be the cause of HUS and microangiopathic hemolysis. So the use of TPE in all these other causes of secondary HUS lacks any evidence from randomized controlled trials. And here's one very useful reference. And another survey tested the routine use of TPE in a diverse group of TMA patients without severe Adams TS13 deficiency. And it showed that there was no evidence of this, which I strongly recommend you read. This review showed there was no evidence for using TPE in these other conditions where Adams TS13 deficiency was not demonstrated. There's been one small clinical study in Sri Lanka which showed no benefit from TPE in patients with acute kidney injury and HUS associated with De Boy-Rousseliae and Hypnali associated TMA. And just to make this point, that it's no good pouring in more anecdotal case reports to the journals. Any number of anecdotal case reports will not prove that this intervention has benefit more than its risk. We need properly designed RCTs to resolve this question. Now, another clinical point, and this is something that's come to my notice over many years. This is the dangers of using the Glasgow Coma Score, which is so valuable in so many situations in acute general medicine. I don't deny that. In fact, a friend of mine, I was trained with him, was one of the co-authors of the Glasgow Coma Score. I'm very much in favor of it. But in the case of neurotoxic envenoming and poisoning, it can be nothing less than lethal for the patient. So here's a case. This is a 9-year-old girl bitten by a Malayan pit viper, Bungarus candidus. And classical situation, she was bitten early in the morning while asleep on the floor of her home. By 9 hours after the bite, they managed, the family, the distraught family, had managed to get her to an excellent specialist pediatric hospital, tertiary referral hospital. But unfortunately, about 30 minutes before she arrived at the hospital, the family say she stopped breathing. She was immediately intubated and ventilated. She was found to have total flaccid paralysis. Her pupils, as you can see here, were fixed and dilated. And she had a Glasgow Coma Score of 3. The diagnosis, the tentative diagnosis, was that she had suffered ischemic brain damage during this 30 minutes between stopping breathing and being very expertly resuscitated on arrival at the hospital. I first saw her 59 hours after the bite. And first of all, we raised her eyelids, we reassured her, and we then asked her to try and move her toes. And I must say some of the staff were pretty amazed that we were talking to someone who was, as far as they were concerned, brain dead. But anyway, we went ahead with this. And to everyone's extraordinary, great surprise, she started moving her big toe. And using simple yes or no answers, we were able to find out that this little girl was fully conscious. She could see once you'd opened her eyes. She could hear the voices of the staff around the bed. You can imagine how frightening that might have been. She could smell and she could feel. She could touch. And this story ended very well because I'm delighted to say that 38 days after the bite, she was discharged from the hospital finally, fully recovered. So I want to list here some of the dangers, I think, of using the Glasgow Coma Score in this particular case of neurotoxic envenoming and poisoning. And there are other situations too. I remember barbiturate poisoning, for example, is another situation where you mustn't trust the otherwise very useful GCS. So these patients with neurotoxic envenoming may have almost total flaccid paralysis. They can't speak or move their limbs. And of course, their lack of ability to open their eyes in response to voice or lack of motor response classifies them as GCS 3. The fact that the pupils are paralyzed and dilated, unresponsive or fixed is another ominous sign. And so this combination of apnea, absent brainstem reflexes, and coma pretty well amounts to a definition of brain dead or brain death in many medical institutions. And very often the misdiagnoses, as in this case, were anoxic brain damage or some mysterious neurological situation, such as so-called locked-in syndrome. And the dire consequence of this may be that assisted ventilation may be withdrawn prematurely because the medical staff have satisfied themselves that the patient is brain dead. The trouble is, of course, or the good thing is that if these patients are adequately oxygenated and perfused, if their respiration and circulation are supported, they may be fully conscious, as in the case of this 9-year-old girl I've just shown you, and able to feel pain, hear and see, and so on, taste and smell. So it's well worth trying to open patients' eyes and asking them to signal by moving their toes or fingers in this situation. This case, these cases remind me very much of a dramatic paper I read in the Medical Journal of Malaysia a few years ago from Terengganu. And it's a very interesting case indeed. I often quote it actually, a story of pufferfish poisoning. So this 69-year-old woman consumed the roe of an ikan buntal for breakfast. A few hours later, she developed some numbness, chest tightness, she vomited a bit, then she became paralyzed and finally had a cardiac arrest. She was expertly resuscitated and ventilated. But 24 hours after the ingestion, she showed no spontaneous respiratory effort. Again, her GCS was 3. Her pupils were fixed and dilated. There were no brainstem reflexes. And the clinicians, the attending physician's opinion was brain death likely, hopeless prognosis, which was passed on to the relatives. But fortunately, the staff here were a bit obstinate, and they carried on with the mechanical ventilation. And marvelous news, at 48 hours, she opened her eyes and began to move her limbs. After 3 days, she was breathing spontaneously, she was extubated, and she eventually made a full recovery. So I think that's an absolute marvelous story. It fits in very well with my snakebite cautions about the use of GCS. Now on to antivenom treatment and the results of the recently published roadmap by WHO, published in 2019, about snakebite envenoming, a strategy for prevention and control. And you'll see that this particular item of the agenda here was to ensure safe, effective treatment. So to make safe, effective treatment available, accessible and affordable to all snakebite victims. That's a tremendous aim. To improve control and regulation of antivenoms. We know there are a lot of rogue antivenoms on the market being unscrupulously marketed, and some of them produced by very substandard manufacturing methods. So the WHO would like to pre-qualify antivenoms in the same way that they pre-qualified, for example, AIDS antiviral drugs. And they're encouraging innovation in research, also on new therapies, which I'll come to later, clearly it's no good having better treatments if the staff aren't trained to use them. So this must always be carried out in parallel with in health workers training and education and so on. And so this is a major part of the WHO's roadmap, which will require nearly $50 million over this period of time to complete this. So to improve antivenoms, the situation is that in many parts of Africa, certainly, but also in South and Southeast Asia, there is no safe, effective antivenom available. And without urgent strategic investment and so on, this situation is not likely to improve. There's much more attention now given to the design of antivenoms. You'll have heard about how in India they're worrying about the design of future antivenoms outside the so-called Big Four that are currently covered by the Indian polyvalent antivenom. And it's also very important to try and regulate manufacturing according to GMP principles, because safety and effectiveness are the key attributes of any therapeutic agent. And sadly, antivenoms have fallen behind almost every other medication in these respects. And most important, investment should prioritize clinical research, that most endangered activity in academic medicine, including clinical trials of the safety and effectiveness of treatments in human patients. So one of the aspects of the WHO roadmap is to alert people to the possibility of new treatments. And a problem is that existing antivenoms, even the best existing antivenoms, appear relatively ineffective against some aspects of envenoming. So prevention of local tissue necrosis, certainly if there's any delay between bite and treatment with antivenom, because after all, tissue necrosis is an irreversible process. Also, reversing or preventing presynaptic neurotoxicity. For example, most Bungarus venoms have a large number of presynaptic as well as postsynaptic neurotoxins. And we know that the presynaptic toxins, which not only block neuromuscular transmission, but also permanently damage the nerve terminals, are not susceptible to reverse by antivenoms. Also, prevention of acute kidney injury. There's some evidence that early antivenom reduces the risk, but certainly a lot of patients currently who've received antivenom will go on to develop acute kidney injury, in the case particularly of Russell's viper, East and Western Russell's viper envenoming. Then there's the prevention of generalized increase in capillary permeability by Russell's viper. And here's just one example of this very highly lethal syndrome: pulmonary edema, conjunctival edema, and parotid enlargement. And this table is too large to go through now, but just to identify, we certainly use anticholinesterases such as neostigmine at the moment to potentiate neuromuscular transmission. And in the case of metalloproteinases, phospholipases A2, there are available enzyme inhibitors. And here are two of the most promising, veresplatin and batimastat. And you see the ones circled here have the great advantage of being orally bioavailable. And preliminary work with animals and in vitro has shown the great potential of inhibiting key enzyme venom enzymes such as phospholipases A2 and metalloproteinases. Now on quickly to the treatment of acute kidney injury. Actually, could I ask you, Carl, I'm getting a bit over time. Would you like me to bring it to an end?
You have another 10 minutes, it's okay.
Is that all right?
Yeah.
Will you give me the cutthroat sign when I'm getting too close?
No worries. We'll finish at 5.
So I said earlier that it was very important that snakebite management should remain part of the mainstream of acute general medicine and emergency medicine. We mustn't just get eccentric and start practicing things that our colleagues in mainstream medicine have rejected. And this is brought to light to me by the KDIGO, which is an international group of nephrologists. And they've produced some guidelines in 2013, and these are some of their recommendations. They recommend not using diuretics such as furosemide or mannitol, and only using diuretics in the treatment of acute kidney injury in the case of volume overload. And they recommend against using low-dose dopamine to prevent or treat acute kidney injury. Well, this is a bit of a shock to me because over many decades, I have certainly used diuretics such as furosemide. I've used mannitol on occasions, particularly prevention of pigment nephropathy. And I've also used dopamine like drugs, I thought, to good effect in treating acute kidney injury with Russell's viper envenoming. So another thing is forced alkaline diuresis, which is popular amongst some Indian physicians who treat snakebite. It's certainly recommended for treating some poisonings. I've treated it for salicylate poisoning and conditions such as myeloma. And it was formally recommended for the prevention of pigment nephropathy in patients with both rhabdomyolysis and also with massive hemolysis. The model here was Crush syndrome. The work was originally done with Crush syndrome. So the point about the KDIGO recommendations, I think we as snakebite physicians should re-examine their recommendations and perhaps be more critical about our own use of drugs which have clearly been rejected by our mainstream nephrologist colleagues, but certainly I have continued to use over the years. And I'm not saying stop using them, I'm saying we must critically re-evaluate our use of these drugs in the prevention and treatment of acute kidney injury. Now moving on to the very contentious issue of fasciotomy. And here is a patient I saw in 1972. Yes, I'm a very old chap. And unfortunately, he absconded from hospital and came back later with clear evidence that he'd had a missed anterior tibial compartment syndrome. This is what one wants to avoid at all costs. That was back in 1972. And when he was followed up by my colleague, Abdul Razak Habib in Nigeria, 40 years later, we heard that this poor chap, well, he survived, but he survived really as a cripple supported by his family. And I think this gives you an idea about what is at stake when you look after a snakebite patient. You may save their life. I was very glad that this patient survived acute treatment. Unfortunately, he then left hospital, so we couldn't complete the deal. And you see, he spent his life being looked after by loving relatives. So that's a tragedy. When I started working in Thailand in the end of the 1970s, I came across some appalling examples of fasciotomy. This is a patient envenomed by the Malayan pit viper, Calycelasma rhodostoma. He'd received, when I arrived at this hospital, he'd already received 20 units of blood. He had had this fasciotomy before hemostasis had been restored with adequate doses of antivenom. Appalling. And here is another example of the long-term effects of fasciotomy. This patient has an extensive area of anesthesia as a result of this extensive and completely unnecessary fasciotomy. So that's the introduction to my quick discussion of fasciotomy. Well, this is a famous Japanese general of many centuries ago undergoing fasciotomy without anesthetic, by the way. Well, I'm glad we don't subject our patients to that sort of thing these days. This is the problem, frankly. Surgeons are easily misled because snake-bitten limbs sometimes exhibit all the classic clinical signs that they've been trained to detect, indicating compartment syndrome or raised intracompartmental pressure. And this can occur in snakebite patients despite persistently normal intracompartmental pressure, well, if it's measured. These are the famous 5 Ps that alert surgeons to the risk of compartmental syndrome. First of all, pain, tenderness on stretching, pallor, pulselessness, because the pulse is impalpable, paresthesia of nerves passing through the compartment, and paralysis of muscles in the compartment. These are the 5 Ps. And the trouble is all these 5 Ps can occur in many patients with severe local envenoming in the absence of demonstrable, provable raised intracompartmental pressure. This was one such case, again bitten by Calloselasma rhodostoma in Thailand, a very tense, pale, apparently pulseless, although the pulse was detectable with this, this ultrasound monitor, very painful and so on. And the surgeons wanted to do a fasciotomy. However, international expert surgical opinion has now discourages fasciotomy in snakebite victims, even in the United States, which was the hotbed of snakebite fasciotomy a few decades ago. So it's now agreed that fasciotomy should never be carried out until appropriate antivenom has been given as soon as possible. Hemostasis has been restored. If you want to restore hemostasis rapidly, you should give antivenom, perhaps with blood products in this particular situation. Most important, after measurement of intracompartmental pressure, direct measurement over at least an hour, with pressures consistently raised above whatever the agreed threshold is. These are common thresholds, would be more than 30 millimeters of mercury, absolute pressure, or a difference between diastolic pressure and intracompartmental pressure of equal or less than 30 millimeters of mercury. And warnings here: compartmental syndrome is potentiated by pressure bandaging and also by excessive limb elevation, which is commonly practiced in hospitals. The snake-bitten limb is elevated very high indeed. That's not necessarily a good thing. And experimental evidence in animal studies suggests that if a muscle is sufficiently envenomed to cause significantly raised intracompartmental pressure, it's likely that that muscle is non-viable. And fasciotomy, as I've shown you, can itself cause prolonged and permanent morbidity. So an absolute condition of fasciotomy in 2021, that's what we're thinking about, should be a demonstration by direct measurement that the compartment pressure is raised over at least a period of 1 hour. And many surgical colleagues complain to me, well, we can't afford the fancy equipment. You know, we can't afford a few $1,000 US for a fancy striker machine. You don't need a fancy machine. Here is a publication back in '75, a homemade apparatus using a mercury sphygmoid manometer and a simple manual syringe. Here is the machine I made for myself when I was working in Thailand, and by the way, which saved many fasciotomies, with a syringe pump and a saline manometer. Here we're directly measuring the intracompartmental pressure. If you can afford a striker machine, that's great. And here are 2 examples. The surgeons were about to go in here, this tense limb, fulfilling all the 5 Ps I've mentioned. But when we measured it, the intracompartmental pressure was only 12 millimeters of mercury, so saved. And in this case, a Russell's viper envenoming in South India, again, surgeons were keen to go in because of the clinical signs, but when we checked the pressure, it was 45 initially, which is high. But over the next hour, patient lying calmly, antivenom treatment, so on, it's progressively declined to a low level. And so this patient also was saved from fasciotomy. So, ladies and gentlemen, here are my conclusions. I've looked at these 9 elements that arose from my critical review of the WHO guidelines and other publications about snakebite. New medically important species of snake are being identified, and well-known species are being found now in unexpected locations. So we must keep in close touch with our snaky friends, our herpetologist friends, and be aware of what there is in the environment, what might be biting our patients. Secondly, we've got overwhelming epidemiological evidence now, at least from India, of what can be the public health burden of snakebite, mortality at least, and there's a need for more national surveys of this type. The point of care testing of coagulopathy is very urgently needed by anyone treating snakebite, envenoming. And at the moment, I'm afraid to say there's no obvious successor to the 20-minute whole blood clotting test, but we must look for, we must be more active in finding a successor. I think the role of plasmapheresis for treating snakebite-associated hemolytic uremic syndrome remains unproven. And until we've got proper randomized controlled trial data, I think we should not be using this intervention. The Glasgow Coma Score is clearly dangerously unreliable and misleading in patients with neurotoxic poisoning and envenoming. Antivenoms must be improved and they must be clinically tested. This is a priority of WHO's snakebite roadmap. Ancillary treatment with venom enzyme inhibitors is a very exciting prospect for the future, and I'm sure we'll see that unfold over the next half or whole decade. Treatment of snakebite-associated acute kidney injury must be brought into line with what is international nephrological opinion. And finally, fasciotomy is rarely, if ever, indicated for snake-bitten limbs. And I'm afraid to say that your ASEAN region is one part of the world where fasciotomies are still done, I fear, far too frequently. So thank you very much for your attention. Carl, thank you for your indulgence in allowing me an extra few minutes or so. And it's very nice to have this opportunity to talk to you on these selected topics. Thank you very much.
Thank you, David. That was a fantastic presentation, and I think you summarized it very well. There are, of course, a lot of area that we can improve on. As you said just now, part of it is just probably not talking to each other. I mean, in terms of the specialities and not talking to each other about the development of evidence and so on, and just follow all methods of treating snake bites. So that's one of the reasons why we have this program, so that we can reach to a wider area of specialties and bring all the specialists together and come to terms with what is evidence nowadays, so our patient can be treated better. So now we will proceed to our next agenda, which is the forum. We will ask our panelists to join in. We have all the panelists here, as you can see on the screen. From Vietnam, Dr. Vanessa. From Philippines, Dr. Emilia. From Laos, representing Laos, Dr. Yok Blasman. From Thailand, Associate Professor Dr. Sataria. From Myanmar, Dr. Miat. From Malaysia, Dr. Zainal. From Indonesia, Dr. Tri Maharani. And we have two moderators for this session, which is Prof. Scott Weinstein from Women and Children Hospital in Adelaide, Australia, and Dr. Sabrina Safri from Ipoh, Malaysia. So we already have a few questions being asked in the Q&A box. So if you have questions, we have currently about 243 participants live. We are also streaming live on Facebook. So there are some participants watching us live on Facebook, and those who are registered here, we have about 243 participants, and we have a few questions already being asked. So we open the session by inviting our two moderators to moderate the session. We will do this about another 45 minutes before we close. Dr. Sabrina and Prof. Scott, the floor is yours.
Well, I'm trying to get my video on. I haven't been successful, but you know, I can't really add much to the treat that we just were given by Professor Worrell. I can only say that with just my voice right now, that there's a couple of major issues that he brought up that I think would be excellent to address for anyone interested in asking questions to the panel from their regionally based. Hang on, I'm just trying to get the video. There I am.
Yeah.
So, you know, one major issue is the importance and the reinforcement, which everyone here knows, about different aspects of general medicine being applied to clinical toxinology practice. And from my experience, there's some people around who just don't seem to want to keep up with all these different facets, interdisciplinary, particularly like the nephrology part, which David emphasized very importantly. And because of that, some of the patients are not quite adequately addressed when they present. So I think I'd open it up to all the panelists and anyone who wants to ask questions, just the importance from their perspectives on which of these concepts are most important in their given region. In other words, when you're seeing neurotoxicity, the focus kind of neurological assessment that's required, the focus kind of background of medical history of current medications. I'll give you an example. There was a patient who presented to our service here recently who had been prescribed an ACE inhibitor and an ARB outside previous to a brown snake bite. And so he presented already with an AKI, even though he was unaware, he was already in early chronic kidney disease. And then, of course, the pseudonaha envenoming insulted that even to a greater extent. So he had an increased level of renal insufficiency on presentation.
Okay, David, you want to address that a bit? Do you have anything to add about that?
Well, yes, I think Scott always brings up very good points because he's a clinician after my own heart. I think that one of the confusing factors in assessing a snakebite patient is their background history, background medications. And again, that can be forgotten. We tend to regard a snakebite patient as coming absolutely virgin from the fields with no other problem other than their snakebite. We forget that that they could well have chronic this and chronic that.
Exactly.
So that's a very good point indeed. And there are other things that can cloud the clinical assessment. I think the psychological aspects, the fear and anxiety are also often misinterpreted. And this is clearly seen in some of these rather naive case reports written by usually they're snaky people describing their own symptoms. They give a perfect description of what in the old days would have been called hysterical overbreathing, although we're not allowed to use the word hysterical any longer, quite rightly. So, no, absolutely right. And of course, the treatment they've had before they reach hospital, whether it's traditional treatment or well-intended first aid of one brand or another, all these aspects may have a bearing on the assessment of your patient.
Okay, good. So Dr. Sabrina, maybe you can put forward the questions from our participants to the panelists and speaker.
Yeah, good evening, Professor Worrell. So basically we have got a few questions with regards to the acute kidney injury. So one of the questions is that the role of using N-acetylcysteine in the management of hemotoxic bites in reducing the acute kidney injury. So in some of the countries, the NAC is relatively cheap and safe and readily available in the hospital. So Prof. Worrell, do you have any comment of that?
Well, first of all, as I'm sure you would agree, Dr. Sabrina, the fact that something is available and cheap is no reason for giving it. And I mean, N-acetylcysteine is certainly a marvelous drug for treating paracetamol or acetaminophen poisoning. And it does have some other, it has, you know, through its glutathione aspects, it has some other theoretical applications, but I know of no evidence for its effectiveness in any aspect of snakebite. And I would honestly not use it until it's been through at least the preliminaries of testing in some model system. I can't think other than the most general terms of why it might be effective. So my simple answer to that is no, we shouldn't use N-acetylcysteine for snakebite.
One of the questions is that with regards to the neurotoxic snake bites, in a few of the cases that you presented earlier, you mentioned that the patient received the antivenom as the major part of treatment. So would you recommend 72? One of the questions asked was, would you recommend 72 hours of intubation and ventilation before making a decision of withdrawing or any treatment? That was one of the questions that been asked.
Yes, well, I think that was very much the point I was trying to make, that in assessing the viability, you might say, of a patient with neurotoxic envenoming, you have to be very cautious in withdrawing life support. And certainly, I illustrated this, I think, with two cases, with the krait envenoming and with the pufferfish poisoning. This does apply to other situations, other poisonings in the field of toxicology. There are more sophisticated ways now of assessing brain viability, imaging and so on, to exclude major anatomical lesions and so on. But no, I think the point your questioner is making is exactly the point I wanted you to take. You should be extremely cautious in making any early or hasty withdrawal of life support in patients with neurotoxic envenoming or poisoning, because we know from these published cases and our own experience that how wrong we can be.
Okay. With regards to the fasciotomy, Prof, how there are questions about how do we convince our surgeons of not to perform the fasciotomy? Even in my hospital, there are a bit of difficulty of to convince our surgeon colleagues to not doing the fasciotomy in a snakebite victims.
Well, I fully understand and sympathize with that situation. I've had the same problem in the United Kingdom. I have discussed with surgeons over the telephone and failed to stop them doing fasciotomies in one or two most inappropriate situations. So it can be very difficult. It can be impossible. I suppose it's a slow process of education. Certainly sending PDFs of appropriate literature to surgical colleagues doesn't always get a very good response. So I think you just have to try and gently point out that, as I say, there are one or two very influential reviews from North American surgeons where their experience with fasciotomy for pit viper envenoming goes back for many decades, as I said. It has been a dramatic change, and it's really involved a critical really audit, simple audit, you know, following patients up and not assuming that every patient who has a fasciotomy and survives is a success. So critical audit, but now that really is a most difficult question. I think you have to gently, politely explain the facts and also the risks. And certainly if there's any risk of persisting hemostatic dysfunction, I think no surgeon would want to be have to take part in a bloodbath on the table. So just a polite and also trying to bridge with our surgical colleagues. So often there's this physician-surgeon divide. It's become a sort of joke in UK about surgeons. But once you get a few friends amongst the surgeons, and I was very fortunate working in Eastern Thailand, beginning of the 1980s, really good relations with some surgeons there. And they were the first to agree and applaud the results when they realized they could be spared doing such a destructive piece of surgery, and much better to get them to concentrate on early debridement of necrotic tissue, of proper management of blisters and abscesses, and most of all, of course, skin grafting and reconstruction, together with the rehabilitation that must accompany any sort of surgical procedure with a snake-bitten limb.
Yeah, I would share the same kind of sentiment to that. I've lost a few friends as well, but gained a lot more after a good discussion. I think Dr. Zainab, Sabrina, in Malaysia over the past few years that we've conducted RECS as the focal point for discussion for patients management after snakebite, and we've averted a substantial number of the practice of immediate fasciotomy whenever there is a swelling post snake bite. So we've showed them the evidence, not the PDF. Yes, we did that before, and we lost a lot of friends, the PDF articles. But what we showed, it was the results after treating well with antivenom. The patients documented about patients' own account of how they feel. The serial blood test that we do before after antivenom, it shows marked improvement. The CK value of start to climb down, and all this evidence. And on top of that, now we also do ultrasound, and we showed where the actual swelling is not really involved in the compartment rather than in the subcutaneous tissue. We also can measure the pulsation of the arteries and so on, which may not be, some people say are not that sensitive compared to all these instruments. It shows all these things are actually present. So that actually helped us in putting forward to them that they become alive, at least supporting us to continue observation rather than going into the OT straight away.
I could add one thing on this, and that is going on with Professor Worrell's comment. In the US, one of the reasons why this was backed off is because it became aware there was no consensus on this whatsoever. In fact, if one goes among vascular surgeons to orthopods, you'll find they give completely different threshold values, including for delta pressure when that's used. Because as Cal might remember from one of the recent ASEANs in Indonesia, there was a bit of a spirited discussion on this, and one ED physician was emphasizing delta pressure as if it was written in granite. And in reality, the only place that's validated for is for trauma. And we don't, and even that is weak validation. We have absolutely no data on whether it could even be used effectively for treating compartment syndrome thresholds in snakebite. So in the US, the reason why that was backed off a bit is because when you have a lawyer behind every bush, you will get sued very thoroughly if you are going into court and they project up on the wall 10 feet high, no consensus value, and then you have performed this procedure.
Well, Scott, with no disrespect to North American medical profession, I would rather opinion was it was influenced by evidence than lawyers, but I know that's the situation you have to live with.
Absolutely. And that's why I said the actual evidence isn't really there. And that's the reason why it's kind of flying bareback if you perform one, and you have to have very solid documented measurements, like Professor Worrell said, in order to justify actually doing this procedure.
Well, there are mercifully some surgeons, Matson particularly, an American surgeon who wrote a monograph on compartment syndromes, who have measured things. And the surgeons who investigate really quickly come on our side. I mean, assuming we're all in favor of rather conservative attitude to a restricted attitude to fasciotomies.
Yes, to give my just final comment from my perspective on this balanced side of things, like David just said, is when Thomas Glass advocated this in the 80s, there was an immediate backlash from snakebite physicians, such as my late mentor, Sherman Minton, and the late Finley Russell, who immediately attacked it, really being aware even then that this was not advisable to as a across the board management intervention. And so, you know, so absolutely evidence was the foundation for the change. But, you know, that kind of other, shall we say, negative reinforcement kind of accelerated the acceptance of it in many circles, even though it is still performed in some places, unfortunately.
Okay, so I think there are questions from Bethany regarding the pre-hospital management of the snake bite, because she is interested to hear the comments from the panel, and also hopefully from other panelists as well, with regards to how do we optimize the use of doctors in the primary care, especially in the pre-hospital care region, and also basically to expedite getting the patient to the hospital as soon as possible, and particularly in the remote or rural areas far away from the definitive care hospital. So Prof. Worrell, subsequently for the panelists as well.
No, I'd very much like to hear from the panel, actually.
Yeah, I invite all the panels for the input.
Maybe Dr. Zana, Malaysian experience.
My experience on pre-hospital care for snake bite in Malaysia, most of the time patients will come to hospitals quite fast, except in some in the rural area in which they don't have the facilities to transport patients. But then the intention to come early as soon as possible to the hospital is inside of the patients. Means they intended to go, but because of the transportation, it's problem with the transportation. But some region for Sabah and Sarawak, for example, Sabah and Sarawak, where the transportation, the land transportation is quite bad, not so good. Still, we have flying doctors in which we managed to get a Mercy flight, to fetch them and then bring patients to the nearest hospital. In fact, even we have managed to bring the antivenom to the patient through via helicopters, and then we bring and then we institute the antivenom on site, and we start the antivenom early, and then bring the patients to the tertiary hospital.
Yes, can I answer?
Yeah, sure.
Definitely most questions. Yes, in Myanmar we don't have helicopter, and that's why this year we train the health assistant from the primary healthcare center. They are not doctors. They are the health assistant. We give training to them, and we are planning to give anti-snake venom, and then they will give the first dose of anti-snake venom at the primary healthcare center, and then they will refer the patient with the referral form to the nearest hospital to get the maximum effect of the ASV. And that is our planning to practice in Myanmar. I think we can start running in next 2021 to get the snakebite outcome to be more effective and good snakebite outcome.
Yeah. If I can also add, with regards to the Philippine experience, we also have quite some difficulties, as Dr. Miat was saying. We really don't have those helicopters, and I can just chuckle. And when I heard Professor Sun saying something about it, and we've tried a lot of ways to reach out to the rural areas through training. We have been able to go to the rural areas such as in the Visayas, as well as in Davao in the past years. Unfortunately, with this pandemic, everything was just shelved this year. But we have also still continued our Facebook reach out chat group, wherein we also received some consultations and also asking for help in identifying the snakes as well. And one of the recent activity that we also had is to have a close collaboration with the RITM in trying to find ways as to the production, for the increasing of the production of antivenom. So hopefully these endeavors will be continued in the next few months, hopefully. And yeah, basically, just to add, as was mentioned, somehow people are already becoming more aware of what to do with snake bites. And recently, there has been some cases wherein they did not kill the snakes, thankfully, and they brought the patients to the nearest hospital. And somehow some cases were addressed properly, and also the time that they end up wasting in the shamans, you call it shamans, we call it albolario in our local dialect. So somehow that step has already been addressed, and people are becoming more aware, thankfully. Yeah. Maybe we can hear from someone from Indonesia. Dr. Tri?
Yeah.
Dr. do you want? Yeah,
In
Dr.
Indonesia have many problems because many island, 70,000 island, over than 70,000 island as difficult problem. And I am working in rural area and the mini hospital and in rural area 7 years. I know one problem is the system from the Ministry of Health about the program of snake bite and all things of snake bite. This training from doctor and the nurses about management snake bite, antivenom, transportation, and the other. And I think different with Malaysia. Malaysia have only problem transport. Myanmar problem transport and yeah, but
Philippines.
Philippines, I think Philippines have program and Indonesia don't have program, don't have uh, the solution about the snake bite. But 5 years I'm working uh, until 2040, 6 years I think. I asked my Minister of Health and give the many thing about problem snake bite in Indonesia. I have the solution. One is the training to nurse and the doctor with many thing, even with REC, with my even Indonesian toxinology, with the Indonesian Doctor Association and the other. And it's a good result. I think the egg here is the heart of the working about reduction the cases of the snake bite and mortality and morbidity have a good result. But Indonesia very big country and many people and many patients about snake bite. And transportation, I think this innovation from transportation uh, with collaboration Public Safety Center 119 in Indonesia. I think if I go to Malaysia 4 years ago, Dr. Ka, yeah, you remember I go to your hospital and look Public Safety Center and your hospital, and I go to the Prof. Dato Abu Hassan Hospital also, and I look this good system to helping many people in Indonesia. And now many public safety center in Indonesia. But I know the difficult problem is the other island, the Java, with the Java. You know Java, Borneo, Sumatra is the big island. But if I go to Papua, I go to the Maluku, it's the big problem to public safety center because with the heli or with the ship is difficult and expensive. And I have the innovation with drone to the send antivenom, send the many things about drug or medication snake bite, and have the advice the doctor and the nurses with the online with phone or with Zoom and the other. I think it's the innovation, and
Yeah.
I hope 2020 after COVID, because now Indonesia and the big problem COVID, I think I hope Ministry of Health have the program of the reduction of snake bite. The planning of the program in the uh, 30 December 2019, but cancel it about COVID in 2020. I hope the COVID end in this year, and I hope start the good program from Ministry of Health to reduction uh, snake bite, especially in the uh, island, in the remote island, because many remote island in Indonesia and many mini hospital and remote location in Indonesia. Thank you.
Dr. Vanessa would like to add anything with regards to the pre-hospital care in Vietnam?
For in Vietnam, for about the snake bite care, I think we have the two top hospital in Vietnam. One in the south is my hospital, Gerai Hospital, and another one is from the north, which is Bat Mai Hospital. I think that these two hospitals, so there are many patients with snake bite there in my hospital. I think so for the next bite care, in my hospital and also in my hospital, I think because we have the antivenom. So in other case from the provincial hospital, they will transfer to our hospital. So I think it's okay. It's not many big problem in Vietnam. But for recently, I just have one a question for about a plasma fibrosis. Because I'm now writing on the King Cobra by so I'm writing for the manuscript. Because I think we have for the last two cases we have the patient with King Cobra by, and they have the communication with the cardiac toxicity, and then we apply the plasma fibrosis. After we gave the patient antivenom, I mean the polyvalent neuro antivenom. But my question is because when I review the research, so I see one research in Thailand, they talk about when they apply the plasma fibrosis in their case for the Bungarus candidate bites, but they didn't have antivenom, and then they apply the plasma fibrosis to the patient, and one case is okay, is become recover. Can recover, but another case look like worse, so the patient still have like more severe, so they stop plasma pheresis. So but as in the speech of Professor David, I also see that plasma pheresis we use it in many cases for hematotoxicity in snake bite, but I don't have any experience if we can do it in the neurotoxicity in snake bite or not in because in reality, for the last two cases when we did it, so I think so. For the cardiac toxicity look like recover, but when I review the results, I only one I see until now I see only one research they talk about that in Thailand, so they share experience about that. So do you think that is correct or not? So that's my question.
Well, no, I mean, it's not correct. That's what I was trying to explain. There are a large number of anecdotal reports of the use of plasmapheresis under its various different names, TPE and apheresis, in the literature. There are a lot, for example, recently from Sri Lanka on things like hypnali envenoming, but also Russell's viper bite envenoming. These individual cases, I'm afraid, prove nothing. And you have to ask yourself, Dr. V, what is the theoretical basis for using plasmapheresis? Certainly, if you have no antivenom, if a patient's envenomed by a snake for which there's no antivenom, you could, I suppose, argue that replacing the plasma would reduce the circulating concentration of venom antigens. And that's the argument that's been used for, well, exchanged blood transfusion as well. If you want to dilute some toxic substance, which otherwise you can't neutralize. But I think that's going to be a most inefficient method in snake envenoming. We know how efficient snake venoms are in seeking out their targets in the tissues. And it's very unlikely that that's going to be affected by plasmapheresis, certainly if the toxin is bound. So I think before you think of giving such a potentially dangerous and expensive intervention as TPE to a patient with snakebite, you have to critically examine what is the theoretical basis for doing this. And just trying it on a patient or two just isn't good enough. That's not what snakebite management should be like. We should be at least as good as the rest of medicine in demanding proper evidence for what we do. It's a matter of ethics as well. Should we be risking our patients' lives by using these interventions in such unlikely situations? And certainly if you have an antivenom, which will in any case neutralize the unbound venom in the patient's blood, certainly, and possibly in the tissues, then the reason for giving plasmapheresis as a diluent of a plasma factor is even less substantial. And as I was emphasizing, the most likely mechanism of hemolytic uremic syndrome, thrombotic microangiopathy in snake envenoming, is damage to the vascular endothelium. That's what's causing the mechanical damage to the erythrocytes that flow past. And that is what is ultimately is threatening the health of your patient. So I really would ask you, Dr. V, I know what an excellent toxicologist you are. You've got to be very critical before you use interventions in snakebite patients.
Yeah, thank you for your advice. But because I consider that, because when I read the research, so I saw that, so most of case, even in Sri Lanka, as you said that, but I also read it, the research also apply on the patient with the hematotoxic in next part. So for those case, in other case, in other country too, Turkey, I remember I read about seven research, even the case series of more than 30 cases, they talk about that for the plasmapheresis apply. And I see that look like they have a right indication when they apply the plasmapheresis, so I agree with that. But for neurotoxicity, yeah. So that is my question. And also, if I also want to ask about your experience for coagulopat, because after when the patient after they receive the antivenom, so for the paralysis recover, so they can move. It's okay. Yeah, so they can do it by themselves. But and then later they have a bradycardia. So I want to ask you for the antivenom, for polyvalent neuro antivenom, it still effect on the cardiotoxicity in king cobra bite or not? Because one case, one research, they also said that for the polyvalent neuro antivenom still effect on the cobra nasa. Sorry, I forget, but that nasa will cause the respiratory failure and also cardiac toxicity. But when they use that antivenom, it still effect for both. I mean, for cardiac and for from neurotoxicity. So this is my question is, if they still effect on the king cobra bite, because if the patient still have the like cardiac toxicity later, so that's also for, I mean, for the polyvalent antivenom, neuroantivenom, so they still effect on that or only just that nasal. So
Well,
that's my question when I
you
do
know,
that.
you know how complex snake venoms are, and we know far more about the proteome, the venome of Ophiophagus hanna than many others. And the antivenom of choice in a patient with proven Ophiophagus hanna envenoming would be the Thai-Red Cross monospecific Ophiophagus hanna antivenom. If you don't have that, then certainly the neuropolyvalent can be expected to reverse the neurotoxic effects. But I agree that the cardiotoxicity, which has been mentioned in a number of in the literature on king cobra bite, might not be affected. So you would have to treat that with by supportive measures. You certainly couldn't rely on neuropolyvalent to solve all the problems of what is a highly complex venom. And if you read the literature on king cobra bites, you'll see a wide variety of effects, not just the neurotoxicity. And this applies to other neurotoxic species as well, such as the mambas, the black mamba in Africa. It's the neurotoxicity may be the earliest cause of death from respiratory paralysis, but it's certainly doesn't represent the entire spectrum or portfolio of possible venom activities.
Okay, we have another 15 minutes. Maybe we can entertain a few more questions from the participants. Dr. Sabrina?
Okay, with regards to the neurotoxicity, neurotoxins, there are questions from the attendees with regards to the role of the electromyogram or nerve conduction studies to distinguish the types of neurotoxins, whether it acts as whether the neurotoxins actually act as at the presynaptic or the postsynaptic, and whether the EMG will help in terms of the diagnosis and also the prognosis of the patient. Because according to the one who asked the questions, most of the antivenom actually is acting postsynaptically. So, Prof. Worrell, do you have any comment?
Yes, EMG, electrophysiological studies, are a useful research technique, but I don't think they play any role in the practical management of a patient with neurotoxic envenoming. The antivenoms available are likely to be much more effective against postsynaptic neurotoxicity than against presynaptic, as I've already explained. The action of presynaptic neurotoxins is not just to block neuromuscular transmission, it also damages the nerve terminal. And so you're not going to get reversal. In fact, we know from animal work that it takes days for new synapses to develop at the site of the disrupted neuromuscular junction to allow a restoration of neuromuscular transmission. So I don't see any role for electromyography other than as a research technique. We used it, for example, in Papua New Guinea in studies of taipan envenoming, and that was extremely helpful. And we've also used it in cases of pufferfish neurotoxicity as well, but as a research technique, probing the mechanisms. In the practical management of a patient, I would have thought it had no value at all. There is just one other situation where it's quite interesting. In Sri Lanka particularly, there have been reports of long-term effects of neurotoxicity, late presenting even effects of neurotoxic effects particularly after krait, Bungarus ceruleus envenoming. And there it would be interesting to investigate these patients electrophysiologically. I saw from by the way, the questions in the chat column, I see there was a question about the use of routine antibiotics for snakebite. Can I answer that? I don't think there is any role for routine antibiotics in snakebite. Certainly if the patient arrives with evidence that the wound has been interfered with, or certainly if there's any evidence of necrotic tissue by the time the patient arrives, I think you must give antibiotics then because of the danger of infection, particularly dangerous things like Clostridium tetani. But there have been a few studies of prophylactic antibiotics, and they haven't shown any benefit. I would rather you waited and observed the patient very critically, and if an abscess, a wound abscess, or definite signs of infection appear, then investigate and treat appropriately. And of course, there is always this confusion between infection and the inflammatory effects of the venom itself.
Most of the cases will have very high white blood count in the acute stage, and they think that that is a secondary infection, whereas most likely it's a reactive thrombocytosis to the trauma and to the bite itself. So
yes,
it will come down. Yeah.
Yes, the neutrophil leukocytosis is very common with systemic envenoming. And as you say, the combination of the neutrophil leukocytosis and a swollen, tender, hot, inflamed limb makes a lot of people think it's they're dealing with bacterial cellulitis.
Exactly.
Mm-hmm. Yeah. Can I just also ask a question for Dr. David?
It would be a pleasure, Dr.
Yeah, go ahead.
Great
yes.
pleasure.
Yeah, so can you comment on the, this is quite controversial, that's why there was an initial hesitation for me to ask, but I think this is very relevant in terms of the anti-venom, use of expired anti-venom, compassionate use of an expired anti-venom, short of not having anything, because that is still a very relevant problem in LMICs, low middle income countries. So what is your take on this, and can you kindly advise as to our approach to this likely controversial use?
Dr. Amelia, I'd be very happy to give a personal opinion, not bound by whatever laws apply in your various countries. In the United Kingdom, we do use expired antivenom. We have a particular process now for signing responsibility. And the use of expired antivenom is, of course, based on a lot of evidence that even though the manufacturer's expiry may have been exceeded, much of the antivenom's neutralizing activity may be retained, possibly even for years, if the antivenom has been conserved at least at 4 degrees in a refrigerator. But this is very much an individual matter. Certainly, if it's a liquid antivenom and the solution is other than absolutely clear, then I would not give it. If there's any evidence of early protein precipitation, denaturation, then it would not be safe to give it. But as I say, there have been a number of studies showing that it can be effective, and antivenoms are so expensive and scarce. it would be really, I think, irresponsible, in my view, my personally unethical, faced with a patient with systemic envenoming, if all you had was expired antivenom, not to use it in that situation. But this must vary from country to country. As I say, in UK, we now have a means of taking responsibility for giving an expired product.
Okay, thank you, Dr. David. Do you have any idea if like the WHO has any position with regards to this expired antivenom?
Yes, the WHO has actually published data in one of its technical reports showing evidence of how well the activity can be retained for a number of years after the stated expiry date. But I mean, there are other variables here. You know, if a vial of antivenom has been on the shelf outside the refrigerator, clearly the conditions applying to that use of that antivenom will be different.
Thank you.
Okay, we have got also Associate Professor Dr. Sataria from Thailand with us today, and also Dr. Yok from Laos. So we would like to ask Professor were any questions or any comments before we finishing in another 5 minutes time.
Okay, thank you. Can you hear me well? So now in Thailand, that from our Thai Red Cross recommendations, because Thai Red Cross is the organizations who manufacture the antivenom. Now they recommend to use non-expired antivenom, and the antivenoms in Thailand is in the National Antidote Project. And because of that, after the expire date, the hospital will destroy the antivenom, the expired antivenom by themselves. That's why now in Thailand, we still use non-expired antivenom from Thai Red Cross recommendations and our Thai National Antidote Project. But sometimes we face the problem with the shortage of antivenom. Like last 2-3 months, we had the problem of shortage of hematologics antivenom also. But we still have enough stockpile of antivenom. So the hospital in our country exchange the antivenom between them, among them, that sometimes in this hospital there is no antivenom, but they use the antivenom from the other hospital, like that, based on the project in Thailand. That the situations in Thailand now.
Well, thank you, Ajahn Sataria. Of course, you're in a very privileged position in Thailand. You have a marvelous GMP production unit there, and the hospitals are well supplied. But of course, everyone would prefer to use non-expired. Let me make that quite clear. I would not choose expired over non-expired. But in less fortunate countries, less fortunate than Thailand, if you're faced with a patient with systemic envenoming and you only have expired antivenom, I would definitely use expired antivenom within the restrictions I've just mentioned. But of course, we far prefer to use non-expired according to I'm sure the rules in all our countries.
Maybe Dr. Yok, yes, would you like to comment a bit your experience?
Yes, well, in Laos, we are not a fortunate country, and especially in the last 12 months, we had a big problem with hematotoxic antivenom. There was no Malayan pit viper antivenom, there was no polyvalent hematotoxic antivenom. And as Professor Worrell said, if you are confronted with a patient after a Malayan pit viper bite bleeding and you don't have antivenom, that is really a terrible situation. And that is the reason I asked Dr. Kal to send me some expired antivenom from Malaysia, so we could at least help some patients out. And for that reason, we treated now 5 patients with expired antivenom. We informed the patient, of course, it's expired, but we believe that it's still working. And the Thai antivenom is, of course, a dry antivenom, a powder. So it's the risk of infection, the risk of bacterial growth in this kind of antivenom is very low. So in all 5 patients, it was perfectly working, these expired antivenom. And we were very happy to have this available. And the situation is still very, very difficult now. So I hope next year we can purchase a new batch of antivenom from Thailand. But it's a severe, I feel like in the last 2-3 years, the surrounding countries of Thailand are more and more purchasing antivenom, and there's a severe shortage. So we cannot get enough antivenom to supply Laos, to supply in the future Cambodia, and also I think Vietnam has also a supply problem. So there's really urgent need to improve the situation.
Thank you very much, Jürgen. Very nice to see you. Of course, your experience reflects that of so many other snake bite hyperendemic countries in the region. I saw one other question in the panel, which is which analgesia should be used in neurotoxic envenoming. Opioids might confuse the picture. They might suppress respiration. My first line analgesic painkiller is always paracetamol, acetaminophen. And you can safely give the full dose without any risk of liver damage. It's a mild analgesia, admittedly. Recently, there's been some exciting information that paracetamol might protect the kidney from pigment nephropathy. And in fact, there's a paper from Thailand, actually in malaria, showing that advantages in protecting the kidney from hemoglobin induced renal damage. So that's an exciting possibility that such a familiar and inexpensive and relatively safe analgesic could have this added benefit. If the patient's not responding to paracetamol, then I think you probably do need to escalate to an opioid, obviously with great care, bearing in mind the possibly sedative effects of the opioids.
Thank you, Prof. Prof. Scott, do you have any final input for the moderator of the day before we hand back to the chairperson? Prof. Scott?
Not really. I just found a lot of the comments from the panelists to be very interesting from each perspective of each region. So I've actually learned a bit myself.
Right. So it's 7 p.m. here in Malaysia. So I think we have quite an interesting section, the Q&A section. With that, I hand the session back to Prof. Khaldun.
Okay, thank you so much, Dr. Sabrina. Thank you so much, SF Scott, and also, of course, all panelists and speakers for your very interesting comments. I would say that we have a very successful program. We had more than 250 participants in total over the 2-hour period, and we have quite a lot of interesting in-detail discussion that I think will help a lot of our patients in our region. And of course, this is not the end. There will be more programs and also continuous efforts in terms of our networking and our in this area, in this region, to help each other. And I sincerely believe that we have done quite a bit, and we are already seeing some very good results in this endeavor of ours in this region, and I hope we will continue doing so for the next few years or years ahead. Okay, so I think I will just say thank you so much to everybody. Thank you so much, David, for your time, and it's so nice to see you from
Yeah.
Oxford, even though it's not face-to-face, but we know it's live, it's not recording. So anyway, this program is recorded. I will post the recording on YouTube in the next few days. So those who missed the earlier part of the discussion and presentation can always go back and review the recording. Okay. So with that, don't forget, we also provide e-certificate for all participants. I have already posted the link to the e-certificate in the chat column. Please just click on the link, and it will give you the e-certificate application. So with that, again, I would say thank you so much. Good night.
Thank you.
Good night
Thank
from
you very
Malaysia.
much, Cal.
Good morning.
Picture.
So
Yeah.
nice
Good
to see you
morning.
all.
Thank
And
you, Dr. David.
seasonal
Dr.
greetings
David.
to all of you.
Yes.
Seasonal greetings.
Merry Christmas and Happy New Year.
Dr. Tri Maharani, I'm
Hi.
waiting to
Hello.
hear from you. Dr. Tri Maharani,
Yeah.
I'm waiting to hear from you.
Oh, yeah. I have
Yeah, it's
a picture from the army from Lebanon. Yeah, I remember it.
Exactly.
I will send you.
See,
Prof.
you
David.
can't escape. You can't escape me. I'll track you down.
Dr.
Okay,
Sab,
guys.
let's take picture.
Yeah, I will screenshot. Yeah, everybody smile. I will do the screenshot. Okay.
Dr.
Okay,
Tri,
ready?
remove your mask.
Okay. Because I am in my ID.
I know.
Okay,
Ah,
ready?
that's you.
1, 2, and 3. Smile. Okay, that's it. Thank you so much, everyone.
Merry Christmas,
Bye.
everyone. Stay
Merry Christmas.
safe.
Happy holidays.
Merry Christmas.
And
Stay safe.
Scott and David, enjoy your chocolates.
Oh, wow. Special treatment.
Chocolate.
Why did you give Scott's chocolates?
He's my teacher too. So
Cal, I warned you, Cal. I warned you.
I'm very transparent. Okay, good night, everyone.
Bye.
Take care.
Bye.
Be safe.
Thank you.